Okay, good afternoon everyone. Today we are presenting a case of congenital heart disease. What we should see, how to take the history, what is the examination, how it asked in the examination, what are the various questions and answers. With me here is Dr. Manogna, who is our DNB secondary resident, so who is presenting the case of left to right shunt in congenital heart disease, what are the presentation and how we go ahead with the case and what are the various things asked in exam we'll discuss today. So now over to you, Manogna. She will present like a typical format of examination, and then we have students with us who can ask the questions and we can give the answers, so that it will be beneficial for all the exam going and who can see this video. Okay, now over to you, Manogna.
Child name is Mokshit, the 7 months old male child, informant being mother, reliable, hailing from Nirmal, presented with complaints of poor weight gain and recurrent respiratory infection since birth. Coming to the history of present illness.
You told two symptoms: recurrent respiratory tract infection and poor weight gain.
Yes.
So once you assess these two patients in context of suppose heart disease or any other illness, what will you take on that? Why recurrent respiratory tract infection? Why poor weight gain? What does it indicate?
Increased respiratory infections means that is increased pulmonary blood flow, sir, which is...
No, that's not the only case. Once you're doing any pediatric case, in the beginning you don't know it's a congenital cardiac heart disease. You have to tell there will be many different reasons. Some may be allergic, some sinusitis, gastroesophageal reflux. So now my question to you, what is the incidence of gastroesophageal reflux in infancy? Usually, exact incidence you see, but usually by 90% they will resolve by 1 year. More the preterm, more the incidence. So that is also one of the very common causes. Other causes you can go from the first to last, like from the lung causes, any bronchopneumonia, bronchiolitis, sinusitis, upper airway problem, lower airway problem. Coming to the cardiac problem, then it's a congenital heart diseases. And coming to the gut problem, then it will be diaphragmatic hernia, indentation, TET, late presentation of TF. So many other things are there. So once somebody present with the recurrent RTI, you should not see yourself as only cardiac, but other cause you have to rule out. So poor weight gain, what does the poor weight gain suggest?
Either intake is less or whatever he is taking is being utilized for some other
very good. So if intake is less, then here the nutrition is to become very important. Second thing, if his expenditure is more than intake, so whatever the cause, whether it is in CCF or some lung infection or is a recurrent RTI, reflux, okay, or some congenital IUGR, where even from the IUGR, it is a symmetrical IUGR, will go continue to have poor weight gain, or some dysmorphic faces. So if the poor weight gain also, you have to think of all those causes, whether it's a recurrent lung cause, CCF, any infection, any reflux, any symmetrical IUGR, or some dysmorphic faces or some syndromic which is having low birth. What is the most common syndrome to IUGR at birth? Associated with cardiac, for example, I give you hint, but towns never have IUGR. I'll tell you, rubella. So what is the most consistent feature of rubella?
Microcephaly.
No. The most consistent feature of rubella is IUGR. Suppose heart disease present in 50%, neurological present in 60 to 70%, but the most consistent feature of congenital rubella syndrome is IUGR. So all rubella usually present with IUGR. So one of the most common cause of IUGR associated with congenital heart disease is presence of left to right shunt is rubella. Down syndrome also is there, but usually they are not IUGR. But they may be, but it's not usually associated. Okay. So these are the two sets of symptoms. Okay.
Yes. Elaboration of the history of present illness. There is history of poor weight gain since birth and history of recurrent respiratory tract infection since birth. And the child had 2 admissions for the same. On the first time, they were told that there was a lung infection. Child was kept in the ICU. The history regarding the oxygen requirement, etc., is not there with the parents. Child received IV antibiotics and were discharged home. Second admission also, child was there on the ward side along with the mother for 2 to 3 days and discharged after giving IV antibiotics.
The important thing you missed, at what time they got admitted?
First one is at 3 to 5 months of age, sir. 5 months of age, and second admission is at 7 months of age, couple of days before.
One important thing what you have to understand, recurrent RTI from birth, from the first day she is having that symptom?
In the neonatal period also there is an admission, sir, that I was elaborating in the birth history.
No. Once you are telling admission or history, that is, what was the condition for which the neonatal admission was there?
That also they were told there was some sepsis, some infection was there with the child.
What I meant to say, usually left to right shunt, suppose if we consider it's a cardiac case to begin with, because we told in the beginning, but if what is the importance of recurrent respiratory tract infection from the birth? after 4 to 6 weeks and after some other time.
Usually left to right shunts, VSD, ASD, they present around after 4 to 6 weeks of
First of all,
life.
I will correct. ASD will never present with CCA
Yes.
or with recurrent at 4 to 6 weeks. Usually all post-tricuspid, that means below the tricuspid wall, that is VSD, PDA, AP window, can present with features of CCF like or recurrent symptoms or respiratory infection from 4 to 6 weeks. Why?
Pulmonary circulation pressures will come down and
so that is not the correct part. In that way, I will tell you two things. There are 3 phases of drop in pulmonary pressures. That is known as drop in PVR. With the first breath itself, the pulmonary pressures will fall. So any pathology which will hamper the pulmonary, that expansion of the chest after birth, will cause the pulmonary artery PV pressure to remain high and not drop. That's why all with the maternal depression, maternal drugs, birth asphyxia, chest deformity, prolonged stage of labor, birth asphyxia, that itself also will cause the PH because the lung won't expand, so they will have a severe PH. And second stage of the drop in PA pressures is because of remodeling. What happened? The arterioles, pulmonary arterioles surrounded by smooth muscle. So they are having thick at birth because there is no flow into the fetal life. So once the thickening, it will produce a resistance. So once the thickening becomes the thinned, that is known as the remodeling of the smooth muscle of pulmonary artery, it will take 4 to 6 weeks. Once that thinning happens, the remodeling of, then only the blood flow will increase. So that's why usually large left to right shunt like VSD and PDA will present at 4 to 6 weeks. Now I'll ask you the one more question. In the same preterm, is it same rule applied?
no, sir, it will be a little bit
Little bit?
early on presentation.
Why? The same principle. In preterm, the smooth muscle at all will not be there.
Less.
So from the beginning, that's why the preterm PDA or preterm large left to right shunt is present as early as even 1 week also. Now the other 2 phases. First is first expansion called 50% drop in PA pressure. Second, remodeling. And third is continuous growth of the volume of the lung and the recruitment of the alveoli. That will continue up to 2 years. So anything like suppose any pneumonia happened, why it causing the PA pressure? Because that will involve the major portion of the lung. The lung volume will come down. Or some syndrome where even this growth won't happen. Like Down syndrome, where the normal acini also is 1/3 less than normal kids. So that's why they are more prone for PH. So that's why if somebody asks you how the PA pressure drop and why left to right shunt present 4 to 6 weeks, this is the answer. Okay. So now
then history of recurrent upper respiratory tract infections also is present, sir. Many episodes, 5 to 6 episodes till now. History of suck cycle was present, and history of sweating over forehead while feeding was also present, as noted by the mother from the beginning. No history of any cyanotic spells, no history of fever with rash or any joint swelling or seizures.
Joint swelling, what is the importance at this age, 7 months? It's important. Why? He got admitted. So joint swelling is the indication of septic arthritis. Because if they go IV cannula, that's why the same symptoms will deteriorate more in presence of septic or septic arthritis. Now, one of the question: what is the mechanism of recurrent arthritis? What is the definition and what is the mechanism? These are the 2 very common questions asked at all level. UG, PG, super specialty, everywhere.
Recurrent LRT.
Why recurrent LRT are present in left to right shunts?
One is increased pulmonary blood flow.
How it will cause LRT?
The increased flows can compress the small airways, which can cause secretions to pull up.
The correct concept is that what is the bronchopulmonary segment? What is bronchopulmonary segment?
The terminal bronchiole. What?
In bronchopulmonary segment, there are 3 structures come in bronchopulmonary segment. What is that?
Terminal bronchiole, the alveolus, and the segmental artery, whichever is supplying.
Oh, lung is supplied by 2: bronchial artery, pulmonary vein, and alveoli. The bronchopulmonary segment includes what? Which is excluded by bronchopulmonary. Pulmonary veins are not there. It runs into the septa. And all 3 are other pulmonary artery, bronchial artery, they are into the bronchopulmonary segment. So when the flow increases, so your pulmonary artery become dilated. So it will compress the nearby terminal bronchioles. So that will cause the air trapping, and that is the nidus for infection. So that is the first mechanism. Second mechanism, there is in some dysmorphic, their improved, their motility all will not be good. Okay, mucociliary clearance may not be good. Third, they are more infected. They have immunodeficient, like suppose D. George syndrome, they are associated with VSD. So that will cause the more. Okay, and they are immunologically deficient when they are poorly nutrition. So these are all 4-5 causes will cause your
Recurrent.
recurrent. So what is the definition? When you call recurrent, in this child you call it as recurrent now.
More than 2 in 1 year period.
See, that is very old definition.
Okay.
Any child, even the one episode which require hospital administration, either oxygen or IV antibiotic or ventilation, that is itself signified that is if it's pertaining to the heart, in presence of heart disease, significant study, that is the indicator for a recurrent RTI. So this child fits into that because there are 2 episodes are recurrent, 2 episodes of RTI requiring IV antibiotic, admission with the distress. Now third, you told suck rest suck cycle. What is the importance?
The child is getting fatigued and unable to feed
Suck rest suck cycle
continuously.
represent it's the adult counterpart of easy
Exertion,
fatigability.
dyspnea with
Exertional
exertion.
dyspnea. So when you call it as suck rest suck cycle, prolonged feeding, when you call it as
Child
normally
takes the-
now as a pediatrician they are supposed to how much time the normal child will feed
Around 25 to 30 minutes total feeding.
total. So that's why in general whenever because it's a different for different child, some child behave differently, they take small without any problem. But as a general mechanism, whenever the child require more than 30 minutes of feeding, that is considered to be
Prolonged feeding.
associated with
Okay.
your hyperdynamic, all autonomic increased activity like sweating, precordial pulsation, breathing problem, cough. So these are all the symptoms of increased autonomic activity to counteract the CC. Okay. So in your history, RTI is present, suck rest cycle is present, sweating is present, tachypnea is present during feeding. So this all suggests what? There is a CCF, underlying CCF if you consider the heart disease. Otherwise also you can tell some have reflux, some have upper airway obstruction. They all again can present in all those things also. But in the context of congenital heart disease, these become very important. Okay, so next.
So the child actually antenatally during TIFA scan itself, mother was told that child has some abnormality in the heart and later further evaluated after birth, sir. So I want to detail the antenatal history at this juncture. Mother is a primary spontaneous conception, baby born out of a non-consanguineous marriage. And first trimester there was no issues, booked a case with regular antenatal checkups, no history of fever with rash, no history of any excessive vomiting. Second trimester fetal movements were felt at 20 weeks, IFA prophylaxis was taken. Mother had a bleeding PV for a duration of 15 days during the second trimester, which was resolved with medications. And third trimester also there were no major issues. Baby delivered by LSCS. Coming to birth history, baby cried immediately at birth and was given to the mother's side, but on third day of life baby had an episode of vomiting followed by breathing difficulty and therefore was shifted to NICU. Their baby received antibiotics in view of suspected infection, and 2D scan done at that time itself had shown 2 defects, 2 holes in the heart. A repeat 2D echo was done at 7 months of age, which showed that one has closed and only one is persisting.
Not 2 things. What is the birth weight?
2.6 kg.
2.6. Is it normal, abnormal for that child?
Appropriate for gestation. It's lower side,
Okay,
but
first.
appropriate.
Appropriate for it. Second thing. Now, once you tell that 2 holes in the heart, it may be normal or abnormal. Even after the detected after 6 months, it may be abnormal, normal or significant, not significant.
It will be abnormal.
Why?
Sure.
So now I'll ask you, what are the 3 holes or 3 defects which is normally present at birth?
PFO can be present, PDA can be present.
You cannot call it as PFO first because it is a foramen ovale.
Foramen ovale.
Second is
Ductus arteriosus.
third, ductus venosus.
Ductus
So all
venosus.
3 can be present at birth. So ductus venosus is the earliest to close within 2 to 3 days, followed by ductus arteriosus. It can be closed by 7 days up to 30 days.
Okay.
So once you call it as the patent, it will be minimum 6 months in a term, and in a preterm it will be 1 year. Then only you will call it as persistent or patency of the ductus. That is the normal time of closure. Third thing, foramen ovale is a normal structure. So whenever the LA pressure, once the child taken breath, the flow to the LA goes to the lungs, then come to the LA, it will close the foramen ovale. But any case, when the left to right shunt increases or LA pressure increases, it will become open because it's like a flap. So even the PFO, PDA can be present at 6 months without any significant toll. And 20 to 30% of the child at birth have small VSDs.
Small muscular
Muscular
can be
VSDs. So
present.
you cannot tell even after 6 months, 2 all closed, one is still patent. That means it's a significant. So it will
But
be
with the
insignificant also.
background of LRTS.
Second thing, now the question are how you detect cyanotic, how you detect heart disease at birth. Suspect, suppose no antenatal scan done.
Yes, sir.
So now there are 2-3 questions. What are the murmur at birth? What are the causes of CC at birth? which will suspect you for cardiac. What are the causes of cyanosis at birth?
Murmurs at birth can be flow murmurs also can be
You
present.
can classify
PD.
what I can suggest like the physiological and pathological.
Pathological.
Physiological murmurs are
Flow murmurs
like
across PD.
the most common physiological murmur is TR murmur. Sometimes first day you can get it. Second day is a peripheral pulmonary artery turbulence because the lungs are underfilled. So it's small, but the flow is more. It will cause physiological PA turbulence. That will give the systolic murmur. If it persists beyond 6 months only, it's abnormal.
Okay.
Third is PDA murmur. Sometimes we get in the
murmurs.
initial days. We have the physiological murmur. Now pathological murmur. Pathological murmur.
Because of VSD or
It is the first. What I told you.
they do not
VSD,
presently.
when the pressures are high on the right side, how the VSD will go? It will not go. So any semilunar wall stenosis can present with murmur because blood has to go through that wall. There is no other option. So severe
Aortic stenosis.
pulmonary stenosis, aortic stenosis, and significant AV wall regurgitation, like in Epstein's or severe TR, organic TR. Sometimes they can present a severe MR. So the murmur present at birth you can classify physiological and pathological. Now, what are the causes of CCF?
Coarctation of aorta.
See, that's what you have to read.
Aortic stenosis.
It's a timeline. Coarctation will not present on first day. Why?
PDA still is
Then when the normal PDA will get closed, I told you 3 to 7 days. Usually coarctation present after
1 week
7
to 10
days.
days.
So what are the causes of CCF at birth?
Critical aortic stenosis.
Critical PS,
Hypoplastic left heart.
hypoplastic left heart, hypoplastic right heart, TAPVC.
Okay.
Okay, or other metabolic causes, all birth asphyxia, or rhythm disturbances, hydros vitalis. Okay, then AV malformation anywhere, AVM here and there anywhere. So, and now one of the very common question, why hypocalcemia and hypoglycemia included in a cause of neonatal CCF? You have any idea? Why it's not included in adult, but why in pediatric age group? This is a very good concept. What is the fuel for the heart? Anyone? Free fatty acids.
Free fatty acids.
Or ketone. So neonates got very poor ability to do gluconeogenesis, free fatty acids or ketone. So they are directly dependent on the circulating glucose. So whenever there is severe hypoglycemia, that itself may cause CCF in a neonate. In the same way, why hypocalcemia is included cause of CCF?
Source for the electrophysiological activity also.
See, what is the T tubules? Where the calcium is getting stored is the T tubules. In a neonate sarcomere, in the neonate myocardial fiber, T tubules are not well developed. That is more common in preterm, where there is no formation of the T tubules. So there is no place for calcium to get stored. Okay, so that's what they are again dependent on the circulating calcium because they don't have any place to store. Okay, that's why even the hypoglycemia can cause. So come to our case. This child has recurrent RTI. They diagnosed had some problem at the fetal age, then developed no problem, but after that some problem developed, and then again recurrent RTI and the poor weight gain. What is the poor weight gain suggest? You already told their energy expenditure is more than what is their intake. Okay, so tell next.
Past history with the 2 admissions with LRTI, sir. And family history, no history of TB contact, no history of any heart disease in the family.
What specific thing you want to ask mother in this? You already told one good IFA is there, iron folic acid. What is the
any other
thing?
drug intake history?
Okay, other drug. What?
Fever with rash.
What are the other drugs?
Phenytoin, any
What
alcohol
cause?
intake.
Alcohol cause VSD.
VSDs.
Even diabetic.
Diabetic.
When the mother is diabetic in the first trimester, when heart development will be over?
6 to 8 weeks.
9 to 10 weeks.
Okay.
So by 10 weeks, if the mother is diabetic, then the 10-fold increase in the chances of congenital heart disease. So that you have to ask diabetic mother. Then rashes. The rashes, what is the importance?
Torch infections.
Torch infection. Second is SLE. So one of the cause for neonatal failure is myocardial depression or low heart rate, myocarditis. So when the SLE is there, what is the most common presentation of SLE in a neonate?
AV blocks and myocarditis.
AV block and myocardial depression. Okay, so that's all you have to lithium, some psychotic drug there that is cause Epstein. Okay, so that all you have to tell. Okay, so diabetes is very important. Then now anything significant in it, then you tell. Now you go ahead.
Developmental history, developmentally up to date as per the age, sir.
Okay. What is the 7 months? What is
7
the red
months.
flag sign? What you call it as red flag sign?
If the developmental is
You tell me
delayed,
up to 7 months, what are the 3 most common red flag signs? Is not present, child is developmentally delayed.
no neck holding.
No neck holding. So neck holding achieved at what
Yes,
time?
3 to 4. He is able to
What
sit
is the-
with support now.
What is the upper red flag sign limit for neck holding?
6 months.
No, 6 months is too late. Social smile, neck holding, and if you do the motor development, neck holding is the major. It should be developed in the 3 months
3
only.
months.
If it goes beyond the 4th or 5th month, that is abnormal. In the same way, social smile should be presented 2 months to 3 months. If it goes beyond that, that is
4
abnormal. So, as per you, the child developed neck holding properly, smile properly. Now, what is the current developmental quotient for the child?
He is able to sit with support, sir. He is rolling over, but
So that
not
means motor
completely.
development
Motor
is
is
okay.
up to age.
Okay.
He is
So
going
which is
and
the most
smiling.
common of all which get affected in large left to right child?
Gross only should get affected.
The gross motor
Gross
only will get
motor.
affected. So just very important concept I will tell you. It's not related to that because it comes up with the point. See, in the initial 3 months, you see, child will do like this. So it will be the upper body. Initial 3 to 6 months, it will be up to the lower body. And after next 6 months, if you divide into 4 quarters, 4, 4, 4, initial 4 months, that's why all the things like this, like neck holding, will be getting first. So in general, the development will go from head to toe. That is a normal 4, 4, 4. You can divide like that. So you come to after 12 months, you will stand. That means your distal muscle, everything will be developed. So it's easy to remember like that. And from the crude to fine.
Yes, sir.
Okay. And then
Central to
from
periphery. Fine.
to
Pincer
that.
grasping. Yeah.
Okay. So that's
Yes.
why you have to do like that. From here to go to the distally finer movement. So like that 4, 4, 4. If you divide, you are able to remember it well. So if even after 4 months these things are not there, neck holding, that is
Red
abnormal.
flags.
That is known as a red flag. Okay.
Yes. Immunization, immunized as per the national immunization schedule, sir. Nutritional history is deficit both in calorie protein also, sir. Calories 300 kilocalorie of deficit and protein 2 gram deficit. Anthropometry length
But
is
what feed he is taking?
he's weaned off, sir. Till 5 months of age he was exclusively breastfed and intermittently they used to give formula. After 5 months they have switched over to
Once
the
you are
cow
telling
milk.
intermittently, then how it will be exclusively breastfed?
Only few times he was given, so not like
So that's what.
completely.
So, okay.
Mixed feeding,
Okay,
and
mixed
after
feed.
5 months it
Okay,
was
it's
cow milk.
deficient. Okay.
Deficient, yes, sir. Now
Okay, so
they
that
are
means
giving
we
him not fully family pot, but they are feeding those things. Anthropometry length is 60 centimeters, less than third centile. Weight is 4.7 kg, less than third centile. Head circumference is 40, around 33rd to
You think
50th
it's
centile.
abnormal,
Sir.
normal?
Length and weight both are less than third centile. So
Why?
only head
See,
circumference
this-
is
okay. So what else?
appropriate.
See, if the length is also getting affected, and
Stunting,
so what do you call it as?
chronic
Chronic. That means
malnutrition.
it's present from the initial days only.
Yes, sir.
Understood? Or sometimes it may be from the womb only. Okay, so you have to see whether although the child developed the normal weight at birth, but after that there is a gross,
Development,
not development, growth delay.
growth delay.
Okay, in the terms of height and weight. So that means both are less. So in terms of cardiac, we call it as cardiac cachexia. So once the poor weight gain, that is known as cachexia. Normally we use this term in tumor patient or where there is a cachexia will be there.
Severe
That means
immunodeficiencies.
your weight loss will be there. So in cardiac, once the cardiac cachexia is there, that is very specific of more flow. So wall you see it's more left to right shunt, and second is more flow in cyanotic heart disease also, like TAPVC, where the more flow is to the lungs and that is causing expenditure of energy in dealing up with the respiratory issues, more insensible water loss rather than getting into the weight. So that's why cardiac cachexia is specific. So if you see, now you finish, then I'll ask. Okay. Anything else?
No, sir. History I finished.
No, but there are so many gross things. Just tell me. Your drug history.
Oh, sorry, sir.
See, 2 things in the history. You have to present till the time you see the patient. So you're not present at the recent admission, why admitted, what suggested to the child. Because you have to see the patient because the patient given to you now. You have to, up to the now of which you present, you have to present the history. Second thing, you not present drug history. What is drug history?
Child has been on furosemide and spironolactone. Sir.
Mother told like that?
She has shown me the medication bottles. On one syrup, 0.5 ml drops, and another one is tablet. She's
But
breaking into
mother
4
not
pieces.
Told. There are 2-3 only medications in the cardiac and pediatric which you can detect. How you detect with the history?
One is the quantity which they are giving and the type of the medication.
Tolofran drops also. So there are 2-3 things. If they are telling with that medicine urine is getting more,
Increased.
that means you are giving diuretic. Second thing, when she is telling you with that drop the motion is coming more black, that means she is giving iron. Somebody is saying I am taking injection every 21 days. Penicillin. Somebody is saying I am taking tablet only 5 days a week. You understood? Okay. So that all you have to understand. This is very important. That will give the clue. Suppose somebody on diuretic. Why? How diuretics help in these people?
Reducing the failure symptoms.
How is reducing? What the diuretic
reducing
will do?
The preloads.
Okay. Preload means preload on right side, left side?
Right side.
So then what happened to left side? Large left right side in the post side more on the left side. So they will decrease the congestion of the lung. Overall, they will decrease the volume. They will decrease the congestion of the lung, right as well as on the left side, both sides. Okay. So that is the important. That is the first history. So if they are on diuretic, that means there is an increased flow situation. There is a failure symptoms are there. That's why they are giving the
diuretics.
Now, one very important concept I forgot to tell. The 4 to 6 weeks, why they are present as a failure? First is a drop in PA pressure and remodeling. Second is what is the physiological anemia of infancy happened? When?
Around 4 to 6 weeks only.
So when there is an anemia, physiologically also will be there. At the same time, PA pressure drop, more flow. In presence of relative anemia, they will present as a more failure signs. So that is also one of the important concepts. Okay. So now you have not told any negative history. You want to give negative history here?
Only 2. One is cyanotic spells, no history of cyanotic spells suggestive of any cyanotic heart disease to rule out, and no history of fever with rash in the child suggestive of any infective endocarditis or worsening of symptoms.
Once if somebody asks you to give, I'll tell you fever with rash may not be infective. It's just a routine atopic dermatitis. You want to get trouble for yourself? No, just tell. You keep in your mind that is the place where you can score point. If they ask, you can tell it may be infective endocarditis, it may be atopic dermatitis, it may be drug rash, it may be just viral exanthem. Then why you want to tell that all those things? Okay, first, you told there is no seizures history.
No history of seizures.
That is why important. Because they may present with the congenital abnormality and they can present with the hypoxia itself can cause seizure in cyanotic as well as acyanotic. Sometimes with fever also they will get febrile seizure, which is very common association. So fever is important. Then your history of admission you told. Then you told rashes.
Joint swellings.
Pain he cannot tell. Okay. So these are the few things you have to tell. Okay. So now with your history, summarize in 4 points what is the important point and give your differential diagnosis. Don't see this.
Okay, sir. 7-month-old Mokshit presented with complaints of recurrent respiratory tract infections and poor weight gain associated with history of suck cycle and sweating over the forehead, and with the antenatal diagnosis of underlying heart disease in the mother and with recurrent admissions.
So while present like that, 7-month-old with diagnosed of congenital heart disease from the antenatal, presented with recurrent RT and poor weight gain and the other features of CCF.
Okay. We can tell like
and
that. Admitted currently for surgical intervention
on
diuretics.
So my most probable diagnosis would be
acyanotic heart disease, most probably
acyanotic heart disease. Acquired congenital.
Acyanotic congenital heart disease.
Acyanotic congenital heart disease. Pre-tricuspid patient, post-tricuspid patient.
Post-tricuspid.
For which post-tricuspid? Large, small, medium?
Probably large.
Why large?
Because of the symptoms and early presentation.
Symptoms present very early. Okay. There is a acyanotic congenital heart disease with large left to right shunt, large left to right post-tricuspid shunt. Then, which is the most common?
VSD most.
VSD, most probably VSD. Then also why VSD? Because that is the most common congenital heart disease. It may be have PDA, AP window. PDA because there is no IUGR, there is no preterm. So although PDA can be present, the PDA incidence is lesser as compared to VSD. So we have to give the most common first. Okay. In CCF,
Not in
controlled
CCF.
CCF, not in CCF.
No. In CCF. Only.
It's a controlled, uncontrolled CCF.
Controlled.
Controlled CCF on medication. Okay, this should be your complete diagnosis by history. So now, with history, anything you want to ask as per your doubts, anything? So now we are going with the examination. So now you have to quickly tell your examination. And I ask you one thing: what is the most comfortable position for examination in a child?
Mother's lap.
First, when it's possible, better to keep in a mother's lap small babies, or during feeding. Suppose he's very active and not cooperating, you can allow him to feed or her to feed. Bigger child you can put. Although you have to remove the all clothes, but here for the sake of comfort, you not remove for comfort. Otherwise, the child will get away. So now just tell me, don't see.
First general examination, child is comfortably sleeping in mother's lap and
It's a comfortable.
with the distress. Tachypnea is there.
See, it's a baseline tachypnea is there.
Yes, sir.
So although child is lying on mother's lap at present comfortably, but there is a discomfort present. Although child is not crying, but there is a obvious tachypnea. Okay.
Yes.
Okay. Then
Head to toe examination, head appears a little big, but
Relatively
big because of the malnourishment.
why malnourishment head looks big?
That is the last thing. There will be a brain sparing effect with the
Brain
nutrition.
sparing effect. So that's why all low birth weight or when it's adequately weight, when the weight reduce, the more it will reduce on the lower part, and which is the last part of the body to show the weight loss. Cheeks, correct. Because cheek has got the biggest buccal fat of buccal fat, so that will go. So once cheek are also getting in, that means it's a very chronic malnourishment is there. So child is lying in mother's lap with baseline tachypnea.
Okay, sir.
Okay, and head is relatively large with the overall looking like a malnourishment. So what you call that term? Failure to thrive. So now that is very common question for a pediatrician. What is the definition or criteria for failure to thrive?
Weight less than third centile.
Okay, not third. I think it's 10th centile. Just confirm
Okay.
first. Okay, then this is the one definition that shows at that point. But suppose failure to thrive in the short term. So the another definition is that once the child cross 2 centile lines, standard deviation centile lines over the short period, that is also considered to be the failure to thrive. Till what age you will consider failure to thrive?
1 year, infancy.
It's up to 5 to 6 years. I think 5 years is the recommended, confirmed, but I think it's up to 5 years you can use the term failure to thrive. Okay. Now, the same history, 2 things I want to ask again. Is there any position where the child is getting comfort?
We should ask whether in upright position baby is relatively comfortable.
And how you determine the NYHA class? What is the classification for symptoms in an infant? For symptoms classification, like you are taking NYHA classification. NYHA classification only applies after 6 to 7 years. Before that, NYHA won't be applicable. So NYHA has got major disadvantage because it's very subjective. Suppose somebody like me who is very fatty, even I go up to 1.4, I get distress without any heart disease also. It's very subjective. In the same way, if the NYHA you are not able to do, what is the best classification, symptoms classification for? They known as Ross classification.
Ross. Okay.
That includes what? Breathing difficulty, poor weight gain, and feeding. Because the main exercise for the infant is feeding. Whether the child is able to take feed. In presence of heart disease, no feeding problem, it's class 1. In presence of heart disease with feeding issues, 2. In presence of heart disease with poor weight gain, this is class 3.
Okay.
And in baseline tachypnea, class 4. So this is baseline tachypnea there or not there?
Yes, sir.
It's a class 4 Ross classification. Understood? So that is very important. You have to read all Ross, Perloff, all other NYHA, all classification which is applicable for that. Okay, so now you go ahead.
And head to toe examination, there is one capsuloid spot on the
What is the importance of capsuloid spots in terms of heart disease? Any heart disease, capsuloid spots are present. It's very common. Heart tumor.
Tuberous sclerosis with
tuberous sclerosis can present with SVT, heart block, LVOT, RVOT, cardiac mass. So if you have multiple capsuloid spots, you have to see for the Tuberous sclerosis also can be
sclerosis.
present. What all symptoms? Because of the C-shape, because of involvement of the muscle. Okay, so that is the one thing. Next, any other thing? Any pallor?
Pallor is present, sir. No
How
ectasis.
you classify pallor? No, classify means how you assess pallor is there.
We have to look at the nail bits, the
Okay.
palmar and plantar
Suppose
surfaces.
it's a cold now.
lips.
So what you will do?
We
You
have
will
to check
check
the
with the
lips and
mother.
tongue. Okay,
Mother
and
also you have to
compare.
check. Show.
Yes, sir.
Hand show. See.
We have to compare
This
the
age is
palm with
stressed.
this.
See.
If the palmar
Mother is
pieces are
more-
also paired, it is severe pallor, less
Okay,
than
the
7.
pallor is there. So that will aggravate all your symptoms. Okay, then anything.
Hair is little bit thin and sparse, sir. Probably
What is
secondary
it?
to malnutrition.
Okay, then anything for sign of distress,
There is tachypnea with retractions and Harrison's sulcus also.
flaring, nasal flaring.
Nasal flaring, very minimal, sir.
Nasal flaring and bobbing. These are the very late
Warning
signs. That
signs.
means it's a warning and impending failure.
Respiratory failure.
Arrest. Okay. So what now it's very common, and I'll ask you why Harrison sulcus? What is the cause for Harrison sulcus?
Because of the respiratory muscle weakness, there will be pulling of the ribs.
Why?
And also due secondary to malnutrition, vitamin D
Why?
deficiency.
Why?
Weak ribs will be there, sir.
Why
Spongy
we
ribs.
Why
which-
respond? See, Harrison sulcus will present at the insertion of diaphragm.
into the
Only they present where the
Ribcage.
diaphragm are getting inserted. Why? In this age, there is no cartilaginous. The ribs are soft, and the anterior cartilage are not calcified, ossified. The ribs are very soft. So with more efforts, that will
gets
getting more indrawing. And where it getting indrawing?
in the insertion of
That's why
Diaphragm.
all Harrison sulcus represent the indrawing where the diaphragms are getting inserted. Apart from that, there is intercostal retraction. So what is the importance of subcostal retraction, intercostal retraction, and suprasternal retraction?
suprasternal is usually secondary to upper airway
Why? It can be present with
obstructions.
lower airway also spasm. So if the supraesternal associated with subcostal as well as intercostal all, that means it's either last sign like a bobbing, the body is trying to maintain the PEEP. And when the intercostal is retraction, that means the parenchyma is involved. Only supraesternal without intercostal, that suggests maybe upper airway. Only supraesternal with subcostal without any intercostal, that also suggests maybe upper airway issues. But not once the intercostal retractions are there, that suggests involvement of parenchyma in the form of more flow, pulmonary venous congestion, pneumonia, collapse, all those. Okay, so child is lying in mother's lap with baseline tachypnea, doubtful flaring, with intercostal retraction, with Harrison sulcus, okay, with pallor, with large head, malnourished. What is the other thing?
Hyperdynamic precordium with
Visible pulse. You can see.
visible apical pulses. Yes, sir.
These are the visible pulsations, the epigastric as well as in the precordial. This is very important sign. When the precordial pulsations are prominent, that suggests either in presence of anemia also it can be there. When large depression, there is more volume, heart is contracting more. It is known as high output failure in absence of even dysfunction also. So able to see the precordial pulsation. On the contrary, if you see the top physiology, where there is an obstruction but there is no hyperdynamicity, that's why you call it as a silent precordium. So hyperdynamic precordium is always a sign of increased flow or associated more flow to the ventricle in presence of either left to right shunt or AV wall regurgitation, anemia, AV and so on. Okay. So anything else, clinical examination. So if without touching the child, suppose if these are the findings for you, what you can tell? With your history now up to this, failure to thrive, cardiac asphyxia is there, baseline tachypnea is there, lungs are involved, Harrison sulcus is there, hyperprecordium is there, and with the history of recurrent arteria and the feeding and all difficulty, and on diuretics. So again you can come up to the contours, the large left to right shunt. But the other things always somebody has to, now why this bulge? See, whenever any bulge, that is known as precordial rock. Why precordial rock? That suggests there is a chronic process. Suppose any acute failure will not see the bulge. Bulge that itself means, and that is more common in a pediatric because of the soft tissue. Because once there is something comes, that soft tissue will give away and give out the bulge. So bulge is a sign of chronic volume overload, okay, or chronic condition. Okay, so there is you can see there is a bulge, the chest deformity. You can see this side is more bulging than right side. Yes. Okay, that means the heart is enlarged. Okay, now this. Now the next thing you have to see is pulse.
Palpation with pulses.
What is the first thing in palpation you will see in a congenital heart disease?
All pulses, whether they are equal
Pulses.
or not.
Okay. Just check. 5 minutes.
Heart rate is approximately 120 per minute, sir. It is equal on both the sides. No radio.
You told all 4 pulses. You will check only
yes,
2 pulses.
no.
What is the importance here?
We should say any radial or radiofemoral delay is present, whether volume is equal on all the 4 limbs. Any difference in the
volume is increased or normal?
slightly increased.
Slightly means there is no doubt.
Yeah.
See, there is nothing like that. Once it's a bounding pulse, that means you have to see the water hammer like, but that is very difficult to see in this age.
Okay.
But in presence of anemia, it always looks little more volumic. But there is no radiofemoral delay. So what we ruled out in most of the condition?
Obstructive
Coarctation. But in what condition of coarctation, even after presence of severe coarctation, you will get the equal pulses all over. You understood the question? No. In presence of large PDA with collateral, the PDA is supplying the lower limb, you will not get in presence of severe LV dysfunction. Upper and lower limb both will be low. In presence of severe aortic stenosis associated, both will be low.
Yes.
Or in presence of large collaterals. Okay, but these are the 3 most common conditions. Okay. Now you told about pulse. Then can you see the JVP?
Difficult to assess in the age group because of the neck.
Okay. The other thing, now ideally we should remove this also. But okay, we'll leave now. So now, what is the next? You did pulse, you did JVPUC, then any other
inspection of the chest also. We have finished.
Inspection,
Next is
palpation should be combined. Okay,
yes,
then
percussion for the heart bodies and
but what is the next in palpation? Most important, any congenital heart disease, to see the situs. That is the most common thing. Why? Because once the situs and the heart position discord, and the chance of complexity will increase. What does it mean by that? Levocardia should be associated with situs solitus. Situs inversus should be associated with dextrocardia. If the situs inversus is levocardia or situs solitus with dextrocardia, the chance of complex congenital heart disease more commonly, cyanotic heart disease will be more. So you have to always see how you will see in small kid, you have to see like
for the
this.
liver and
This is the liver, and then you will see here the dullness. So this is the liver.
Yes, sir.
Then
Spleen.
this is the tympani.
Tympani.
So which space you will see the stomach tympani? What is the space known as?
Rob space.
Space. So you should know. They will ask you the boundary of that. Now, just see. Pulsations are prominent. What is the definition of apex beat?
Where the most prominent pulsation.
Apex. Outermost.
Outermost and most prominent.
No, it cannot be. You won't see. You will see the parasternal more prominent. This is known as L. So outermost and lowermost pulsation. The precordium is known as apex beat. What is the apex beat here? In which line? In which?
It's in the 5th intercostal space, sir, just lateral to the midclavicular.
It's a normal, abnormal in this age.
4th it should be.
4th it should be, and it should be not cross the
midclavicular
line. So now there is one more question for you. Midclavicular line and midline of clavicle is different. You have to understand that. Okay. So here we are seeing the between 2/3 and 1/3, and then we are doing. It's more than that. And it's what is the pulsation? What kind of pulsation? Again, hyperdynamic. Because it's in the more than one space. Okay.
Spreading more, it is hyperdynamic.
Okay.
It is heavy.
So this is hyperdynamic, which is suggestive, and there's a lower C. It's C up to that. Not even 5th. 1, 2, 3, 4, 5th. So it's very low and down. So it's suggestive of LV. Second thing, once you see the pulsation, if you are seeing the pulsation in continuity with the parasternal, that is more suggestive of RV.
Both.
Suppose RV is getting enlarged, so that means the pulsation will be present up to here, total. Once LV will be there, there won't be any pulsation, and then you will see the parasternal. So that is the difference between RV and LV in terms of the chamber localization. Now, third thing.
Look for parasternal heaves.
Touch in second space touch. No, second space touch. See, there is a loud palpable sound.
P2.
What is that loud palpable sound?
P2 probably.
P2. Okay. So that is the P2. That means there is a severe PAH is present. Okay. Then you see, ideally this is the way.
Or we can keep pen or anything and see for the lifting.
Okay. There is no lift present, but there is a visible. That means your RV is also contracting more. RV is also hypertensive. So, important point, pulse are good, hyperdynamic pulsation, palpable P2. Okay, so that is suggestive of
biventricular,
which is more dominant?
Left.
Left. One more thing you forgot in your clinical examination is the
AF.
AF. Okay. Now this is there. So now without auscultation, again we come up to the same pipe. Biventricular, severe PH, LV apex, and then it's more suggestive of large post-tricuspid.
Left to right post-tricuspid shunt with associated PAH.
With associated PH. Now you auscultate. What do you expect now? My question is, what do you expect now?
Probably post-tricuspid shunt with PAH. It should be a pansystolic murmur associated with loud S2, wide split
See,
S2.
now I'll ask you one thing. Why you're telling pansystolic when presence of severe PH? Now your concept is very difficult actually. Once LV and RV, what is the origin of murmur? How the murmur? There will be consistent pressure difference should be there.
Left to right.
In two of the chambers, whatever you are seeing. So it's a left to right shunt, so there should be LV pressure should be high and RV pressure should be low. Then only blood will go. Once the severe PH, both pressures are high. Then
Shunt will decrease.
not shunt will decrease. Shunt will be same, but it will be not producing murmur. So it will produce only short systolic murmur. Understood? So the more the larger the shunt, the murmur will be shorter. In the moderate, when there is consistent obstruction, then there will be pansystolic murmur. When there is very small, there is only early systolic murmur. So there should be pressure in large shunt. What is the RV pressure and LV pressure?
Equalized.
So then you will get any murmur? No. But what is the murmur if you find out that such as a large shunt? Then you see the MDM
Diastolic murmur.
at the apex. Okay. So then that is the concept we should not forget. First, what is the definition of PSM? Pansystolic murmur, what is
Begins
the
with S1. We cannot hear it clearly, and S2 also will be muffled, and it will have it throughout the systole. We can hear it.
No, it's not. A pansystolic murmur starts after S1 or with S1 also.
Along with S1.
And then continues up to the systole, and before S2 it will stop. What is the definition of continuous murmur?
Throughout systole, diastole, we can hear.
Continuous murmur is a murmur which starts anywhere in systole, masking the second heart sound, and ends anywhere in diastole. Okay. So these are the 2-3 things you have to very clearly you should know. Okay. So now just do the auscultation. I'll just allow you to do only 3-place auscultation. What you will do, you do. Important you see why she is seeing with the bell, because the MDM, mid diastolic murmur, that shows the large shunt at the mitral wall. That is a low pitch murmur. So you have to see with the bell. Okay, that's why we are seeing the anything. Tell your findings.
Yes.
S1,
Loud
S2.
S2 with ejection systolic murmur, short systolic murmur.
Okay. See, there is a short systolic murmur. The two things, ejection murmur, you should not any comment in the lower sternal border. And pansystolic murmur, you should not comment on the upper sternal border, because upper is always the outflow. So there is a two murmurs. If you see, there is a short systolic murmur and there is a flow murmur which is radiating up to the clavicle also. So that means there will be increased flow towards the pulmonary wall. So that may also will cause murmur, flow murmur. And there is a MDM, which is a low pitch murmur, diastolic murmur at the apex. So that itself suggests it's a large shunt. And the loud P2 will be there, and the single sound. Why single sound? Same. When the PA pressure A2, P2 will come. When the PA pressure is high, the valve will close very early.
A2 closes early, but P2...
A2 closes early, very early, and that will not able to see.
Here. Only P2 we can hear.
So that's why it's all the decrease in the A2, P2 gap, we will able to hear only single heart sound. Single heart sound in such case also suggestive of large shunt. But the most common is the MDM and your hyperdynamicity and the symptoms of CCF. That suggests a large shunt. Okay. So now what else you want to see? Anything else? So once you are seeing the LV-S3, that itself. S3 is a normal kid this age or abnormal? It's a normal at this age because there is a hyperdynamic cycle. What is the cause for S3 normal?
Increased flow towards...
that is early filling phase in the ventricle. So in pediatric ages, the tachycardia early, their volume is already high. The S3 is normal. Okay. But even if the S3 present in expression, inspiration, all phases, in all positions, that S3 is abnormal. What is S4? Cause for S4?
against a stiff ventricle due to atrial systole.
So the S4 is always
Abnormal.
but you can see S3 is normally present in early age group. S4 is normally present in elderly age group. Okay, so that is the thing. Okay, so now as per you, there is a loud P2, there is a short systolic or no pen systolic or MDM is there. So that itself suggests a large shunt.
Post tricuspid left to right shunt.
Okay, so what is your complete diagnosis now?
Yes, 7-month-old, yes, sir. 7-month-old Mokshit with antenatally diagnosed congenital heart disease, born to a non-consanguineous primary mother, presented with complaints of poor weight gain and recurrent respiratory tract infection with the symptoms of CCF, congestive heart failure.
What I
On examination,
what is
diagnosis? Diagnosis most probably, yes, sir.
Not most probably. Tell.
Acyanotic congenital heart disease with large left to right shunt with pulmonary artery hypertension.
So you want to tell like that. Situs solitus first.
Okay.
Situs solitus, acyanotic congenital heart disease, post tricuspid shunt, most probably VSD, large in size, associated with severe PH, then in CCF, on diuretics, no evidence of infective endocarditis. In Ross classification, 4. So that much you have to tell. Okay. So this is like that. So now anything you want to ask or add on this, whatever we are having?
I don't
now
know.
for
Nothing
just because
much,
we tell, what is the AF concept? When is the AF should be pulsatile, non-pulsatile normally?
Usually pulsatile.
Pulsatile. It may or may not. But when outer table will be closed, when inner table will see, there is a very good concept. The inner table close first, outer table close last.
Okay.
So even if the inner table close, you will able to see the bony, but you will not find any pulsations. And you will not find any bulge also. The outer table will close late. So whenever it's more than 1 year, 9 months of inner table and more than 18 months or 15 to 18 months of outer table, then it's abnormal.
Okay.
Then when the large fontanelle present at birth, what are the causes?
Hydrocephalus.
Okay. Any pressure which is increased, or even if not, and posterior fontanelle will close by?
Usually at birth or
within 1 month. If it persistent beyond, that is a sign of hydrocephalus, hypothyroidism, rickets. Which is the most important suture, or you will see to diagnose the hydrocephalus?
Metopic.
Metopic is here.
Petrosquamal
suture. That is present. That is definitely there is some increased pressure inside. Okay. So this ends with our general physical examination. Now to complete that, what do you want to see now? X-ray or ECG?
Both, sir.
Both you will see, but what do you want to see first?
X-ray.
Is X-ray helpful in getting your diagnosis of VSD?
No, sir. We'll know cardiomegaly. We'll know with.
I'll ask you, what are the things you missed in examination? We're not taken BP.
Taken, sir, but
mistake. Even from examiner side, not to ask. Second is saturation. Pulse oximeter.
4-limb saturation and 4-limb BP.
Now this is the X-ray. Is this consistent with your diagnosis?
Yes, sir. There is pulmonary plethora. There is cardiomegaly.
See, to differentiate PDA, AP window, VSD at this age will be very impossible, almost impossible. But second thing, in the older age, when you will see the aortic root dilatation, then there is more suggestive of PDA because the PDA will go. So now the question I asked you, what are the chambers getting dilated in VSD?
Post tricuspid, it will be left and right, both will be there.
Tell me the chambers. Tell 4 chambers dilated in, 3 chambers dilated in VSD. See, the chambers will get dilated only when the blood stay in that in diastole. So from the left to right shunt, where the blood will go? LV to RV. RV will get dilated? No. RV will never get dilated. Why? Because at the same time when the LV is contracting, RV is also
pushing out the blood into pulmonary.
So it will directly go to the
pulmonary.
Pulmonary artery is the first chamber which get dilated. From pulmonary artery, blood will come to
LA and LV.
LA, LV. So which are the chambers getting dilated? LA and LV. If somebody asks what are the chambers getting dilated in VSD, the pulmonary artery, LA and LV. In the same way, PDA blood will come from the aorta to the pulmonary artery. Pulmonary artery again go to LA, LV and then aorta.
Aorta also will be.
Aorta will also be get. In the ASD, blood will come from LA to RA to RV.
RV and
again LA.
pulmonary.
Pulmonary artery. LA will get dilated in ASD. No. Why? Because at the same time it will directly stream to the RA side. It will not stay. So these are the important concepts because these are the findings you will see on examination also as well as ECG X-ray also. So this is the X-ray which shows you to tell is well centralized. No, it's little rotated.
Rotated X-ray.
Second
The
thing,
AP view.
situs for to start with.
Gastric
No
bubble and
stomach
liver.
bubble seen, but there is a liver shadow is seen here. Okay, then second thing is a
Exposure,
cardiomegaly.
cardio.
Okay, and the diaphragm is
Unequal.
diaphragm is hyperinflated.
Hyperinflated and
What
flat.
is the importance of hyperinflation left to right shunt? In left to right shunt, we already told there is a micro alveoli which is getting air trapping that will cause the hyperinflation. So hyperinflation in large left to right shunt is a sign of
Severe
CCF in a less than 1 year. So that is a hyperinflation. Cardiomegaly. Okay, and then there are end-on vessels. You can see these are the end-on vessels. And the vessels were able to press below the diaphragm in the periphery and end-on vessels. So this all suggests you of your
Increased pulmonary blood flow.
Although what is the apex?
Everted up and.
See, the thing is when the diaphragm is already hyperinflated and in a small, even after the LV is dilated, you will see the rotation of the heart, which is causing the apex to not typically show the LV
Down,
apex, which is
like
very rare because the biventricular forces are prominent. So you will see the still RV apex. Okay, so this is consistent with the cardiomegaly, RA dilatation, rotated heart, with the plethora, with the end-on vessels, and the vessels you can able to trace, and the hyperinflation suggestive of large shunt. But which large shunt? PDA, AP window, VSG, we cannot. Okay, so that is a typical X-ray which shows the CCF feature large shunt, but we cannot categorize. Okay, this is the ECG. So ECG is a nightmare even for cardiologists, senior people also. But if you are able to see the basic 4-5 things, then you are able to decipher 80% of the ECG. See, once you see the ECG, you should tell these are the 4 leads 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5. These are the 12 lead 1, 2, 3, 4 channel. So 12 lead, 4 channel, and somebody giving the ECG, you should ask firstly what is the age, because here we know this is the ECG of a 7-month-old child. Okay, with 12 lead ECG, 4 channel with the rhythm, lead 2 as a rhythm strip. Then you will see the standardization. So on this, it will be voltage in this axis. It will be
Speed.
Time. So you see, what is this suggest? This box is suggestive of standardization of voltage. Normally this box has to be 10. But now it's a 5. That means it's a half standardization. So that means whatever value you are getting for the voltage, you have to make it double. And what is the initial part? Initial part represents the chest lead. No, limb leads, and the later part represents the chest lead. So sometimes you will see the half year. They will represent separately for chest and limb lead. But here if it's with the 5 box, that means it is for both limb as well as chest lead. So this is the voltage, and for the time you see 25 milliseconds. So that means the speed of the strip is normal. Here also you can see 5 mm millivolt. Normally it has to be 10 mm millivolt. That means it's a half standardization. So whatever value is there. Why we do the half standardization for the voltage? Because whenever there is a hypertrophy something, you see the complexes are
Big.
Mixing with each other. You will not able to read. So to that you need the half standardization. So you are able to differentiate the 2 lead complexes very well. Even after that we are not able to remove. That means still there is it's a high voltage complex. So there are 2 reasons for it. So now you have to go with the normal QX heart rate. So heart rate, big box, 300 divided by big box, or 1500 divided by small box. You can see there are 10 small boxes between 2 QRS or 2 big boxes. So 10 small boxes means 1500 divided by 150, 300 divided by 2 big boxes, that means 150. 150 is the heart rate. So sinus rhythm or not, the definition of sinus rhythm is every P followed by QRS, and P axis should be normal. The rhythm should be generated from SA node. So the P axis should be between 0 to 60 degrees. That means 1 and AVF should be positive. So see, 1 and AVF both are positive. Okay, that means it's a normal sinus rhythm. Then QRS axis, you see which has got the maximum voltage. Maximum voltage is around 2 AVF, and which has got the equiphasic AVR, so that will be perpendicular to that. So that means it's around the 90 degree QRS axis. Okay, that shows even biventricular forces. Then the chambers here, if you see the S compared to C, this is RR dash. Here also positive, here also positive. So that means it's a biventricular hypertrophy will be there. But you have to see the Q waves. But once the Q waves are there, The chambers are dilated. You have to take V6, V7, V8, V9 also. And all congenital heart disease, you have to take even right leads also to detect the dextrocardia. Because it's a dilated, you keep only up to V5, so you will not able to see the Q waves. You have to take V8, V9, V10 also as posted. Then you are able to see. So this is very much, then the P peak, that means P pulmonary is there, P is broad also, that means P mitral also. It means RA, RVs both are dilated. Both ventricles are dilated with the LV forces more dominant. And then QRS is 90 degrees, that means the biventricular forces. That consistent with our clinical diagnosis of biventricular forces with prominent LV forces with severe PH. Okay. So if the ECG is a different topic, you have to take it differently, but these are the in general you can tell. So this is the way you have to start seeing the ECG for all. One of the important points in development is a hypertrophy related or volume related. In volume, you can see your complexes are big, your T waves are also big, but there are no deep Q waves. Deep Q is also present in volume mode, but it's a deep and wide and associated with ST changes, that is on a strain pattern, that is the suggestive of hypertrophy. Pressure overload. Volume overload, there will be big complexes, T wave prominent, Q waves prominent, but Q wave will not be wide. It will be deep, but it will not be wide. And then there won't be any ST changes. So once the ST changes are there, that means subendocardial ischemia is there, that is hypertrophy, demand mismatch is there, that is suggestive of your hypertrophy. So more complexes, bigger complexes, T prominent with a deep Q but not wide Q, and no ST changes are suggestive of volume overload. Long forces, large forces with STT changes and deep and wide Q is suggestive of pressure overload. Okay, just to tell, this is the, because there is no Q wave seen at all, so we cannot comment, but there is no ST changes. So we can easily tell there is no LV, hypertrophy or ischemic pattern that is related to the volume overload. So, in short, what we can tell with the history is suggestive of large shunt with evidence on clinical examination also. So, if you tell the 10 points, Manogna, what are the 10? So now, with the everything, tell few points on the history, examination, X-ray, ECG, and tell your differentials, how you come up to the conclusion.
Yes. From the history of poor weight gain, recurrent respiratory tract infections, it probably that it's an increased pulmonary blood flow kind of a lesion, so left to right shunt.
And the onset of the
illness is
first.
Quite early, so it should be probably a large.
Already diagnosed at the
Antenatally diagnosed.
Admitted, mother told for surgery on diuretics. They all suggest an increased flow situation in absence of cyanosis, history of cyanosis, aggravated cyanosis on examination. That shows the acyanotic
heart disease.
On examination, it's a failure to thrive. Then hyperdynamic precordium, loud P2,
palpable P2, loud P2.
Then this suggests there is a
precordial bulge.
An LV apex, precordial bulge, that shows a chronic volume overloading. With the LV, the apex is down and out. With the parasternal impulse and loud P2, that shows even PH as well as the biventricular forces. With the MDM suggestive of large shunt. And in presence of retractions, Harrison sulcus, and nasal flaring. And the associated complicating thing which is present most of the pallor, anemia. Okay, so these are things. Now they are differential with the X-ray ECG, that shows X-ray also shows plethora with the cardiomegaly. Okay, that is suggestive of large flow to the lungs, hyperinflated lungs. ECG also biventricular forces with prominent LV forces, that is also suggestive of biventricular forces, large forces. And that is suggestive of hypervolumic volume overloading condition. And so the differential, what you will put 1, 2, 3.
VSD, large VSD.
Large VSD. Second,
AV canal defects.
Fair enough. AV canal, multiple shunts. So first we will tell VSD, then PDA, AP window, or the combination of these, like AV canal. AV canal is common in which condition?
Downs.
Is any dysmorphic faces? No. Okay, now what is your management? No.
Medical management in the initial phases. If
for what? Medical initially you have to continue that medical management till the child got operated or getting intervention. What medical management?
Diuretics to prevent recurrent infections also, reduce the exposure to the child, vaccinate adequately as per the age.
Okay. And what is the most common viral infection associated with congenital heart disease? RSV, parainfluenza, influenza. These are the most common. When they are present, the outcome may be sometimes dismal also. So you have to avoid those infections. You have to vaccinate for that. Third, this is one. Then you have to assess If the child comes with the CCF, you have to give the dobutamine, you have to start the digoxin or diuretic, oxygen, propped up. Then this is the first thing. Second thing, after initial stabilization, control of infection, control of anemia. Then you have to think of if the large shunt, you have to do something either surgically or percutaneously. At present, the percutaneously without surgery, if it's possible to close the hole, you can close with the device, or if not, then you have to go with the open heart surgery. So this should be your, and long term, you have to tell mother. See, if the VSD is a simple, it's a almost curable condition. If no complication happened, once you close the VSD without any complication, the child life may be normal. So sometimes you have to tell mother also, because mother until it is diagnosed, still they continue to you to give that hope. If we close properly and if we are able to follow, the child may have a normal life. So you have to see prognosticate also. Like if you do the top, although there may be possible, but there are many complications for which they have to admit it or undergo some other process later also. So although it's a treatable, but it may not be curable, or they may require multiple interventions later also, like arterial switch also. But the VSD, if no complications, it's a straightforward VSD, then it's more or less it's a curable. ASD, VSD, PDA, the onus is on the pediatricians or onus is on the cardiologists to treat all those things because they are nearly curable. So you have to plan as per like that.
Yes.
Okay. So thanks a lot for your time and your inputs. So hope it will be beneficial for the students. We'll come with the more other cases like that to help for the benefit of this. Okay. Thanks a lot.
Thank you, sir.